slide, but one of the bigger gaps that was demonstrated was this lack of understanding around how to stage syphilis. While syphilis rates are going up across the country and in Baltimore City, there's still many folks who haven't seen syphilis, don't know how to stage it, and ultimately, because they weren't sure how to stage it, may not be treating it in the most appropriate way. And so, with that, we were very lucky to have Barbara Wilgus in Baltimore, who not only, as I mentioned before, runs the Prevention Training Center, but just really is a great partner with Baltimore City Health Department. And she is kind enough to be willing to come on and really give us kind of a crib sheet on this determining syphilis stage and treatment. And this is what I was calling the educational content. This will be posted on the web. I just ask you to offer us a little bit of grace to because it's not going to be on tomorrow. But we will get it up on the web and the provider portal for BHB. So without further ado, I'm going to turn it over to Barbara.
Okay, good morning, everyone. So yes, I am going to give you a brief overview of syphilis staging and treatment. I will say at the very outset, as a resource, if your program would like a more in-depth training, because I'm going to talk about a lot of complicated things in a short amount of time, please reach out to us at the STD/HIV Prevention Training Center at Johns Hopkins, and we can definitely provide more in-depth training for your program. Next slide. So natural history of syphilis. So to note, sexual transmission only occurs in early stages of syphilis. So there is a graph, I think, hopefully on the next slide, that will show the various stages. So you'll see here primary, secondary, and early latent stage are considered early syphilis. This is when sexual transmission occurs. Vertical transmission of syphilis, so maternal child transmission, congenital syphilis, can occur throughout any stage of the infection. Additionally, the longer one has syphilis, the more complicated or longer the treatment may last. And also on the right hand of the slide, you'll see the complications of syphilis, which can occur in both early and late stages. So this makes a difference in how you are going to adequately treat your patient, but also how infectious the person may be to their sexual partner and how likely that it may be that they could be reinfected by their partner as well. Next slide. So I do want to say a word before starting about your syphilis staging, syphilis testing. So these are the traditional and reverse sequence algorithms. When you order a syphilis test at your facility, it's going to be one or the other, and every facility is different. Many large-scale labs now do the reverse sequence algorithm, which you see on the right, where you start with a treponemal test. So this is an antibody test which will have a positive or negative result. The treponemal antibody is specific to syphilis, Treponema pallidum. However, you can have false positives. So when you have a reverse sequence algorithm, if your treponemal test is positive, you want to do a non-treponemal test. If it is positive, then you go down your pathway of determining what type of syphilis the person has, if it's been treated, untreated, etc. If the non-treponemal test is negative, you want to do a tiebreaker treponemal test to determine if the original test was a false positive or a true positive. And then you have your decision tree from there on. On the left-hand side, go back. I'll tell you when to switch. On the left-hand side, you see your traditional algorithm with non-treponemal testing, where you start with a non-treponemal test. This is a different type of test which will come out with a titer, and I'll show you examples of that in just a second. It is not necessarily specific to syphilis. So if your non-treponemal test is positive, then you want to get the treponemal test that is specific to syphilis to determine whether the case is an actual positive syphilis test or not. Next slide. I do want to mention that point of care and at-home testing, which is actually if you're doing a lot of field work, or people can now get a home syphilis test. These are all, so the two on that you see kind of on the left-hand lower part are FDA cleared point of care tests that are CLIA waived. And for syphilis testing, and then the at-home, the now diagnostics syphilis test is for over-the-counter use. All three of these are treponemal tests. So by themselves, they would be what would be considered the start of that reverse algorithm. So if you do still need an RPR titer to be able to manage these patients appropriately and also do the algorithm to make sure it's not a false positive. Next slide. When we talk about titer response and looking at serologic testing, you want to actually see when someone is treated for syphilis, you'll hear a provider say fourfold decline or twofold decline. A fourfold decline, you can see on the left hand, you actually have to decrease the titer that that a syphilis test that an RPR will go to by fourfold. So see on the left-hand side, this person had a titer of 1 to 32. Once they were treated, it went down to 1 to 8. There is no statistic difference in a 1 dilution titer decrease. So if you see titers that are 32 and 16, 32, 64, that is actually just part of the testing, and it doesn't actually show an increase or a decrease. The RPR test has been around since Victorian times. It is dependent on a human being to look at a lab test and see dots until they stop seeing dots. And so it is prone to some variability. So keep that in mind when you're looking at your syphilis titers. Next slide. So really for staging for syphilis, this is where we're going to go in now to what you do to actually stage syphilis. And the first rule of thumb is that any patient you see that has a newly positive syphilis test, they need a complete head-to-toe physical exam, including a pelvic exam or speculum exam. And the reason being because the patient in front of you may say, I'm not having any symptoms at all. Syphilis symptoms can be variable and easily overlooked. And so even if someone says they're not having symptoms, they may not actually understand what they should be looking for. And it's up to you as the provider to do a full physical exam so you can actually know what stage it is. Next slide. So let's go into stages. So primary syphilis is the earliest symptomatic stage of syphilis, and it tends to appear somewhere, between 2 weeks to 90 days after someone has been exposed. The kind of hallmark symptom of primary syphilis is a chancre, which is a lesion that appears at the site of inoculation. So you see down in the left-hand corner, someone has a chancre on their lip from oral site of inoculation. So it can be extragenital. Typically is painless. You see several different presentations, and I do have a speculum exam one in here. This kind of looks like it should be cervical ectopy, but actually is a chancre directly on someone's cervix. Typically are painless, but up to 40% can have painful lesions. Typically is one single lesion, but many people have multiple lesions as well. And in general, once the primary syphilis manifestation happens, regional adenopathy happens near the area of the lesion. So the person with the oral lesion, they may actually have cervical adenopathy in genital urinary manifestations. They're going to have more inguinal nodes. Next slide. I want to mention again, syphilis loves to throw you a curveball. So if someone has lesions, but they are painful, or they are multiple, or sometimes they might actually have HSV co-infection along with syphilis infection, or mpox along with syphilis infection. So keep in mind that presentations may not be your kind of classic presentation. Next slide. Once syphilis enters the body, it then becomes a systemic infection. So while still early, the next stage is secondary syphilis. Next slide. So this one has turned up very weird. So I probably have 2 or more slides that actually show you the go back manifestations of secondary syphilis. The clinical spectrum can be vast. Most commonly, you hear about skin and mucosal surfaces affected, but you can have complicated early neurosyphilis, which would be anything involving the nervous system, ocular syphilis, which can affect any aspect of the eye. Next slide. Syphilis pneumonitis, musculoskeletal manifestations. I've been seeing actually a lot of arthralgias or single joint arthritis that winds up being related to secondary syphilis. So again, your full head to toe exam looking for new onset of symptoms. Kidney nephrotic syndrome, if you happen to be getting other like a metabolic panel, you may see changes in renal function. Syphilitic hepatitis is a secondary syphilis manifestation that can involve hepatic lesions if you actually are getting, imaging, but also elevated liver function tests, particularly if the alkaline phosphatase is higher than the ALT and AST. Next slide. So these are some of the more classic presentations that if you open a textbook, you're going to see. In general, I am finding that syphilis is now trying to kind of throw a curveball again. So the kind of classic rash that you've heard about is on the right upper side of this slide, which is the palmar plantar rash. So you see this macular rash on the person's palms and the soles of their feet, the macules of which will cross the lifeline and sometimes can look scabby or scaly like this. I am less frequently seeing the palmar plantar rash, and nowadays more frequently seeing what you see in the middle, which on the left-hand side, on the left-hand middle person, you can barely see it all. It's more prominent on the right-hand person. But a macular trunk rash, which does not fall in, it kind of generalizes through the whole trunk and back. Doesn't fall in sweat patterns or other things that you might think would be tinea versicolor, for example. The top left are mucus patches. Many times someone may either not notice it, or you may look at this and think, oh, this is geographic tongue, which is a deviation of normal. Generally, the way to know the difference with a person is ask them, have you had this on your tongue for your entire life? And if it's a new onset, then that has to raise your suspicion for a secondary syphilis manifestation. Down on the bottom here on left and right, we have condylomata lata, which are warty looking well, they don't have to be genital, but in this case, they are genital lesions that are kind of moist in appearance, but do have a very warty appearance. And they are moist and kind of smoother on surface than a traditional HPV-related wart. These are teeming with syphilis. If you took a biopsy of either one of these, you would see syphilis spirochetes all the way through the surface. So these are a few of the secondary manifestations, and generally too, generalized lymphadenopathy is another thing that you may notice with secondary syphilis, that on your head to toe physical exam, even if some of these other symptoms are fading, if the person has large lymphadenopathy, that keeps you in your secondary syphilis stage as well. Next slide. And just to note also that just like everything else, syphilis rashes will try to fool you as well. So these are just some images, and to the left-hand side, a graph of some atypical cutaneous manifestations. So again, a person may get a syphilis rash in an area where it is in their skin folds, and may look more like an eczemic kind of rash. These are things that you need with your good history taking and physical exam to determine are syphilis or new onset since having syphilis, which can actually put the patient in one of these early stages. Next slide. I do also want to say a word about neurologic manifestations of syphilis, because a person can have neurosyphilis at any stage of their infection. A person can have asymptomatic neurosyphilis, and many times you should consider this if a person doesn't respond to their syphilis treatment. They could actually have compartmentalized asymptomatic neurosyphilis, which would require longer treatment and different treatment. Typically, neurologic manifestations of syphilis, again, are going to be kind of more meningovascular in early neurosyphilis, and your kind of classic tabes dorsalis later in syphilis. Next slide. This is just actually showing you, this is usually on one slide here, so this is actually just showing you the various presentations of neurosyphilis. Next slide. Another aspect of neurosyphilis are your otic and ocular syphilis, which do happen in any stage of the disease, and ocular syphilis in particular being an emergency, requiring emergent ophthalmologic examination. Both otosyphilis, which has clinical manifestations of ringing of the ears, vertigo if they have an inner ear infection, hearing loss in one ear, acute hearing loss, and then ocular syphilis, any manifestation from the eye, floaters, redness of the eye, conjunctivitis symptoms, beginning to have blindness in one eye. They should be referred to an emergency room, and actually they do not need a lumbar puncture to diagnose the case. It's actually based on their ophthalmologic exam, and the diagnosis is presumptive, and they should proceed immediately to neurosyphilis treatment with IV penicillin and corticosteroids. Ocular syphilis, if not managed immediately, can become permanent blindness. So it's really important to screen for this and know when to treat it as well. Next slide. These are just simple questions that you can ask your patient during your whole head to toe exam. For neurosyphilis, any new headaches, new weakness, new seizures, any new onset of gait difficulties, memory, personality changes. And then ocular syphilis, I have people look at the white wall and tell me if they see floaters, if they have any pain in their eyes, redness, changes in their vision. And then ringing of the ears, vertigo, those are kind of, non-specific questions for syphilis, but part of your whole workup to determine whether a person has complicated syphilis or not. Next slide. So then you've done your whole head to toe exam. Yay for you. The person doesn't complain any symptoms, and you don't find anything on your thorough comprehensive exam. That is when you are going to get into latent syphilis. So latent syphilis is when there is positive syphilis serology in the absence of clinical signs or symptoms of syphilis on head to toe exam. Then you need to stage by when the person last had a negative syphilis test. So early latent is when a person has positive syphilis serology, no signs or symptoms, and you definitely have a negative syphilis test that occurred within the year, so less than 1 year. True late latent syphilis is when you have currently a person with no symptoms, they have a positive syphilis test, and you have looked and in conversation with our wonderful partners at the health department, determined that the person has indeed had syphilis for longer than 1 year time. Say they had a positive syphilis test a year ago and were never treated. Those are patients that are considered to have true late latent. What now is kind of occurring at increased frequency is when a person is determined to have latent syphilis, but you have no previous test within the year. So they have no clinical signs or symptoms, and you cannot prove that they had syphilis at less than a year's time because you don't have a previous negative test. Anyone that is considered unknown duration, regardless of their titer, regardless of anything else, if you have done a head-to-toe exam, no signs or symptoms, but you have no previous test to base duration of treatment, those patients must be treated as if they are latent, because you want to be able to be sure that you have adequately treated the patient. So titer levels by themselves can't determine what stage it is, even if you suspect it's early. Next slide. So this is actually putting the treatment of syphilis kind of all in one. Do the first box here. So primary, secondary, and early latent syphilis are adequately treated with 1 shot of benzathine penicillin injection. So 1 time adequately treats the patient. Next box. When you're looking at late latent infection or unknown duration, then that is 3 shots of bicillin weekly. And then the final slide, when any of the complicated syphilis, so any neurosyphilis, either ocular syphilis, otosyphilis, any neurosyphilis, and then your late stage tertiary syphilis, which is when you actually have organ destruction due to syphilis. That is all complicated syphilis management requiring 10 to 14 days of IV penicillin. Next slide. So speaking of benzathine penicillin, that is your treatment of choice, and that is the only treatment if someone is pregnant. An alternate if someone is non-pregnant would be doxycycline, very less frequently ceftriaxone, and not recommended azithromycin. But you may hear from other countries that that is used in other places. But primarily benzathine penicillin, 2.4 million units, 1 time for early syphilis. Next slide. With your late latent or unknown duration, again, this is going to be 3 doses of benzathine penicillin, 2.4 million units. The important thing you need to understand with pregnancy is that this is very important to time your dose specifically, because during pregnancy, it's much harder to keep therapeutic levels in for the full duration of time. So in pregnancy, whereas sometimes not being pregnant, there's a little bit of forgiveness if somebody misses their appointment for their 2nd or 3rd shot. You have a little wiggle room of about 10 days. In pregnancy, really, you need a strict 7-day rule. If it's more than 9 days, you have to restart the whole bicillin series. So you can start to see how it would get more and more complicated to treat someone adequately if they haven't been staged properly and you are trying to treat everyone with 3 doses, getting them actually in a timely manner to prevent congenital syphilis and adequately treat the patient is a lot more complicated in the setting of pregnancy. Next slide. So I want to say again that a wonderful free resource available to you if you have any questions about syphilis staging on your physical exam, you can put in any of this information to the STD Clinical Consultation Network. It gets routed to actually probably my boss next door, Dr. Ghanem, who wrote the book on syphilis. Um, and um, and and just to make sure that you have staged appropriately any other follow-up information that you need. And again, we are happy to provide more in-depth trainings for staff and go over complicated syphilis cases if you wanted to have a grand rounds. These are all things that are available to you from our Prevention Training Center.